सर अभी फुल स्क्रीन आ रहा है ना?
No, not yet, sir.
Just give me a minute. I will just change
Yeah,
the
yeah,
view.
sure. So, with all your permission, I'm starting the session.
Yeah, yes.
Good evening and a warm welcome to all the dignitaries present here. I'm Shreyushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, hosted by the Society of Oncoanesthesia and Perioperative Care. And the focus of today's session is perioperative blood and component therapy for cancer surgeries. So let's begin today's session, for which I would like to invite Dr. Shohan Solanki sir to take over. Sir, you can proceed with the talk. Over to you.
Yeah. Thank you very much, Tracy. And I wish you all this happy Independence Day. Although this is not really happy for us because one of our colleagues has suffered a very bad thing in Kolkata, and she's no more with us. So we all condemn this act. And with this, we go ahead with our today's 56th webinar on perioperative blood and component therapy for cancer surgical patients. So, because we all know, because major surgery required did lot of blood and component therapy. So, for today's topic, we have our chairperson, Dr. Rakesh Garg. So, he's professor at AIMS Delhi, and we all know him. He is a very well-known person. He's also editor-in-chief of IJN, our own journal, JOPM. So we don't need any introduction for Dr. Rakesh. So he's I think one of the best person to take this session forward. So Dr. Sir, please, stage is yours.
Thank you so much, sir. Thank you for the kind opportunity and interacting with this excellent topic for the day. I think perioperative blood and the component therapies for perioperative period in cancer surgeries is an important topic. And there are a lot of new data which are coming up, which is being refuted by older concepts. And even the WHO is continuously propagating some important aspects of judicious use of this precious therapy. And we have a very good speaker with us today, Dr. Vinci Sanapala. He is very well trained for it and is a fellowship holder as well. And presently is working as assistant professor and Department of Anesthesia, Critical Care and Pain Medicine at Actrek Tata Memorial Center, Mumbai. I'm sure that he's the right person for taking us through the various nitty-gritties of the appropriate and judicious use of blood and blood components in patients undergoing cancer surgeries. Dr. Vinci, please.
Thank you for the kind introduction, sir. Good evening. At this outset, I also wish everyone Independence Day. Thank you for this opportunity, Dr. Sohan sir and the team of SOPSI academic cell to let me giving me opportunity to speak on this topic. The topic for today, which was given to me, is perioperative blood and component therapy in cancer surgery. Right. Coming to the cancer management, the surgical management is the most preferred and effective method in reducing the tumor load in the body. And coming to blood transfusion, it is one of the major component in patient care of a surgical patient. Right. So when we coming to the topic, which is a cancer surgery surgical patient and blood transfusion, both are having multiple implications to a oncoanesthesia. Main problem with blood transfusion is being limited availability, which requires processing and storage, maintenance of that storage, and it is only available on donation. It is not prepared or manufactured in any of the laboratories, right? So we'll just start our session with a small case summary, which is a 56-year-old female, no comorbidities, who had a locally advanced CA rectum status post FOLFOX chemotherapy and radiation, neoadjuvant, planned for total pelvic excenteration, who has come just 3 to 4 days prior to the planned surgery to the preoperative clinic, who's on examination, whose effort tolerance was fair, with no much significant past history. Hemoglobin was 9, platelet count was 2 lakh, and other coag lab values were within normal limits, ECG was within normal limits, heart rate was around 98 with normal sinus rhythm, BP was 110/70, saturation was fine, and planned for surgery another 72 hours after her visit. And intraoperatively, she has undergone extensive surgery, which was done for almost 8 hours. The final blood loss was around 4.8 liters. 10 crystalloids were given, 3 PRBC, and just 2 FFP were given. Postoperatively, patient was shifted to ICU with the vitals of 130 per minute, BP of 120/60 on high dose of NORAD with a lactate of 7. Persistent NORAD requirement was there with high colored drains in the postoperative period, for which the surgical team has re-explored. No bleeder was found, with diffuse ooze was there along the parietal surface and the surface of the bowel, leftover bowel, or again persistent more supplementation of blood and component therapy was done. After a turbulent postoperative course, the patient has recovered for almost 10 to 12 days after the surgery and recovered gradually. So there are many things which could be improved in this particular case scenario for this particular patient, where her outcome would be more better and her post-operative course or intraoperative management would have been more better. Well, let's see if we could manage the same case better at the end of this session. So, the main question to all whoever are attending: why do we transfuse blood or blood products? The main thing, is it for a plasma expansion? No. Intravascular volume expansion? No. It is mainly for tissue oxygenation. Oxygen is the most vital component which is required for all the peripheral tissues, right? So how the oxygen is delivered, because the oxygen which is there in the atmosphere has to be delivered to the peripheral, the most peripheral of the cell, right? So oxygen is a passenger, the vehicle is hemoglobin, and the road is plasma, right? So the oxygen which is picked up from the lungs going into the blood goes to the tissue through hemoglobin and plasma. So for oxygen delivery to happen adequately, there are two important components. One is hemoglobin, two is partial pressure of oxygen. So for these two, even if these two are there, there should be a proper delivery mechanism like cardiac output, right? So delivery of oxygen is mainly dependent on cardiac output and content of oxygen in arterial blood, right? So if you could see here, content of oxygen is mainly dependent on two factors, and majorly on hemoglobin, and some component of partial pressure of oxygen also plays a role in maintaining the content of oxygen. Partial pressure of oxygen is mainly for the delivery of the oxygen. It is a dissolved form, but the bound form is hemoglobin. So finally, delivery of oxygen is cardiac output into the formula which you could see. So now the normal delivery of oxygen is per minute is almost 800 to 1200 ml per minute is delivered every minute. But how much oxygen is really required by the tissue? It is just 200 to 250 ml per minute, right? The body is delivering almost 4 to 5 times the amount of oxygen which is required for a normal metabolism every minute, right? So the margin of safety is almost 4 to 5 times, right? So now if you could see in this graph, it is a graph against VO2 and DO2. So VO2, it is divided into two ways, where the delivery independent VO2 and delivery dependent VO2. So here where the DO2 is maintained well, the VO2 means the oxygen consumption doesn't really depend on the delivery of the oxygen, because it is always giving more, means 2 to 3 times or 3 to 4 times more. And in any scenario, in any women's clinical scenario or any of the scenarios where the patient's delivery is decreased by 1x or 2x, the VO2 doesn't really affect, means the metabolism at the peripheral tissue doesn't really get affected, means the maintenance of aerobic cellular respiration persists even on decrease in delivery of oxygen by 1x or 2x of the normal delivery, right? So there will be one critical DO2 point, where below that, if the delivery of oxygen decreases, the utility of oxygen completely depends on the delivery, means it will become delivery dependent. Once the delivery is decreased and it is not meeting the supply, then the anaerobic respiration sets in, the lactate accumulation increases, and you could see the lactate if the persistent VO2 decreasing is matching with the increase in lactate values, right? So these are some physiological aspects of blood transfusion which we have to know before we transfuse blood. Right. So another component of it is, so do we think that increase in hemoglobin, does increase in hemoglobin through transfusion? If I have a patient who has hemoglobin 8, over a period of some 6 months, she has some renal disease, anemia of chronic disease, and she has hemoglobin of 8 for a period of 6 to 8 months. She was in that hemoglobin of 8, and she's planned for some surgery. And if I transfuse hemoglobin, is he transfuse plaque cell for that patient, does the delivery of oxygen really improve, or the utilization of oxygen, does it really improve? It's a big no, because the, as discussed in the previous graph, it always, if there is an oxygen debt, then only the VO2 improves. So till then there will be no, if there is no oxygen debt, means there is no requirement of oxygen, means there is no increased requirement of oxygen at that particular level. The just correcting the number of hemoglobin from 8 to 9 or 9 to 10 will not really show up in increase in oxygen consumption, right? So if you could see the physiological response to anemia, if the patient is anemic over a period of time, so eventually the patient, the body has to deliver oxygen to the peripheral tissue. So it can improve the cardiac output. By increasing cardiac output, it could increase the heart rate, or the decreased viscosity also decreases the systemic vascular resistance, enhancing the delivery of oxygen. And also there will be increase in 2,3-DPG in the red blood cells, which will decrease, which will get the oxygen dissociation curve to the right, which will decrease the affinity of oxygen to the hemoglobin and increasing the delivery, means offloading of oxygen to the tissues. So these are the physiological compensatory mechanisms which would happen in a patient. So this is also one component of physiology which we have to have in back of our mind when we are going ahead with perioperative management of a borderline hemoglobin patient or an anemic patient or an intra-op anemic patient, whatever. So these all come into play to take a decision. So once the hemoglobin blood part is done, there is a major component which helps in hemostasis is blood components, right? That coagulation factors, platelets, and all. So when there is an injury to the vessel, you have to just imagine that this as a, you can just analogous it, it is similar to a damaged PVC pipe. When a damaged PVC pipe in the blood, water leaks out from that, immediate response from our side is we just will put a waterproof tape on it, which is equivalent to platelets. Over it, we'll just make some end seal and put it over it. So once the end seal is solidified, we will just show off the extra part of the end seal so that the PVC pipe is smooth. The same thing happens now, which we are doing extraluminal. The same thing will be happening intraluminal in a blood vessel. When there is an injury, there will be exposure of endothelium, which activates the platelets, which will make the platelets which are normally moving, which will make them sticky. So once the stickiness of the platelets increases, there will be formation of a platelet plug. So this platelet plug activates thrombin, which helps, which eventually convert fibrinogen to fibrin. Fibrin is a solidifying, it will more stabilizing. It's a stabilizing molecule of the platelet plug. Once the platelet plug is stabilized, and there will be further activation of coagulation cascade, which would further improve the thrombin, increase the thrombin levels in the body, so that the blood clot is more stabilized, and over a period that stabilized clot and should not hamper the blood flow. That will be lysed by plasmin, by fibrinolysis and clot degradation, and it will be cleared off with the macrophages which are circulating. So it is always important to maintain a balance between prothrombotic factors and anticoagulant factors, and also antifibrinolytic factors. So in a situation of thrombosis, the procoagulant factors will increase. And in a situation of bleeding, the procoagulant factors decrease and anticoagulant factors in the body might increase. So there is another classical example which we would have studied in our training period. The liver disease affects both and eventually forms a balance of procoagulant and anticoagulant factors. So you could see in the diagram where we could have an idea of which pathway would affect which coagulation test. The extrinsic pathway usually affects the prothrombin time, where factor 7 is usually tested, and activated APTT is the reflection of mainly the intrinsic pathway, which happens inside the vessel. Right. So coming to blood component. Sorry, intrinsic pathway has extrinsic pathway happens within the body. Sorry. Coming to blood components, the whole blood, when it is collected from a donor, is centrifuged to form a packed cell concentrate, buffy coat, and platelet-rich plasma. So the both of them are separated in two separate bags, and platelet-rich plasma is further centrifuged at room temperature around 20 degrees centigrade to form another platelet concentrate separately, and a platelet poor plasma will be floating above, and that will be freezed. If it is freezed at minus 20 degrees, it forms plasma. If that is what is fresh frozen plasma, it will be almost 200 to 300 ml, depending on the amount of blood collected and amount of patient's plasma volume, donor's plasma volume. Fresh frozen plasma is produced from that, is processed from that, and then further, if fresh frozen plasma is further thawed and centrifuged, and it forms a cryoprecipitate, where it will have more concentrated quantity of coagulation factors. So cryoprecipitate is required to be freezed at -80 degrees. And further, whatever is left over is just factor 8 poor plasma, because cryoprecipitate is considered as a factor 8 rich plasma. So coming to the blood components, what each blood component has also is required for an onco-anesthetist to know at what phase of a surgery or what phase of the patient's management, what blood product has to be selected or ordered to avoid unnecessary blood transfusions. So PRBC, one unit usually rises the hematocrit by 3% and hemoglobin by 1 gram percent, but the equilibration would happen over a period of 24 hours. And FFP 1 unit of 20 or 250 ml contains all the coagulation factors, but there will be a relative deficiency of factor 8, and it rises fibrinogen by 400 to 900 mg per unit. Platelet concentrate, there will be random donor platelets and single donor platelets. Random donor platelets increases the platelet count by 5,000 per microliter, and single donor platelets increases the platelet count by 24,000 to 35,000 per microliter. It is stored at room temperature. There is increased risk of bacterial infection. These are all we usually know. And cryoprecipitate, each unit consists of around 30 to 40 ml, which is, as we have discussed in the earlier slide, which is rich in factor 8, 1 Willebrand factor, fibrinogen, and factor 13, because it is a concentrated part. So after getting to know about the basic physiological basis and blood components, what do they do? So there is, in 2015, American Society of Anesthesiologists have published practice guidelines for perioperative blood management. So it is an updated report, 2006 report, which was published earlier. So let's go through the recommendations and where we could improve our practice. So it is more or less in concurrence with the patient blood management, which is a multimodal patient blood management strategy, which has 3 pillars, which is pillar 1 is optimizing the patient's own blood cell mass, or red blood cell mass, and minimizing strategies. These are different strategies. Each pillar has multiple strategies involved in it. So pillar 2 is minimizing the or bleeding, and pillar 3 is optimizing patient's physiological reserve in relation to anemia. So eventually everything will avoid unnecessary, minimize the bleeding which could be avoidable. Right? Coming to patient's evaluation. Review of, so there are further multiple steps at which this recommendations were given. In patient's evaluation, review of patient's previous medical records is very important. If the patient had required any previous blood transfusions, what is the cause for it? Drug-induced coagulopathy, is there any history, or any previous history of thrombotic events, and what are the medications they are on for the same? Is there any risk factors for organ ischemia, like ischemic heart disease or previous transient ischemic attacks or a stroke history? Or counseling the patient. If you find the patient is at risk of, it could be the surgery wise or it could be the patient wise, at risk of increased transfusion perioperatively, it is required for the perioperative physician to advise and counsel the patient regarding the risks and benefits of blood transfusions, and further lab tests if it is required to evaluate any particular derangement or any significant history which requires further evaluation, or lab tests are recommended. And a physical examination, if required, is to be done. And a preoperative evaluation to be done in concurrence, means at the same time of evaluation of for blood and blood product transfusion. If there any patient is riskier to have or receive blood transfusion, it is always advisable to perform a preoperative evaluation along with that, so that it will improve the strategies to mitigate the blood loss and as well blood transfusions. So, and the next is pre-admission patient preparation. So, just prior to the admission, we can prepare the patient once the patient is evaluated and now plan for surgery. So, there will be ideally, if we plan it properly, we could get some 3 to 4 weeks of time for optimization of patient or addressing any issue which is required or improving, which would improve the patient's outcome. Like erythropoietin with or without iron infusion or iron therapy, reduce the need for allogenic blood in selected population, like patients with CKD or patients with anemia of chronic disease, patients who refuse to get transfused blood from other donors. And if you happen to find out that the patient has anemia or a borderline hemoglobin, and other clinical symptoms or clinical signs are pointing towards there is some problem with blood production or nutrition, it can evaluate for iron deficiency and it can be treated and addressed accordingly. And discontinuation of anticoagulation therapy, if any, according to the depending on the surgery basis, and again a risk to benefit ratio benefit has to be weighed upon. Blood and component availability also to be confirmed. So pre-procedure preparation. Next is pre-procedure preparation. So this is for the healthcare team, healthcare providers to prepare for what all has to be optimized, like blood management protocols. There should be multimodal protocols involving so there should be a protocol which is to be in place for any institution involving the transfusion medicine surgeon, anesthetist, and a critical care physician. Some protocols have to be instituted, so that what are the transfusion triggers for the patient population which we are handling, what are the tests, or what is the way we could monitor how soon we could get the blood test reports, and availability of viscoelastic assays. So depending on these, we'll have to formulate a protocol so that everyone would be adhering to it, so that the patient would be benefited better. And restrictive versus liberal transfusion strategy has the restrictive blood transfusion strategies means transfusion threshold of around 8 gram percent has shown to have lesser mortality, fewer cardiac, neurological, and pulmonary complications, and a shorter hospital stay as well. So that is restrictive transfusion strategy is recommended by ASA. And avoidance of transfusion and reduction in volume lost is also to be followed. Like again, same, the multidisciplinary management, like preferring a minimally invasive technique over open technique, or planning cross specialty consultation for like hematology consultations would improve a patient's perioperative blood loss, get down on the amount of blood volume lost during the surgery. And massive transfusion protocol should be in place, and everyone has to be aware and trained accordingly that what is the massive blood transfusion protocol, and again, it also has to be with closed loop communication and all. And maximum surgical blood order schedules. It is like assessing the amount of blood loss which happens for that particular surgery, and cross matching and reserving the adequate amount of blood, and during the surgery informing means keeping the blood bank in loop to increase the amount of blood available for that particular patient if the blood loss is increasing or expected to have increase. Right? Pre-procedure preparation. So same, the continuation of it. Reversal of anticoagulants if the patient is on warfarin. If there is if urgent reversal is required, prothrombin concentrates can be transfused, or if it is not available, FPs can be transfused. And a non-urgent reversal, if we have time for and it is optimal, a patient vitamin K can be preferred. And antifibrinolytic prophylaxis is proven to be beneficial in knee replacement surgeries and liver surgeries, and also surgeries which are labeled to be having high risk of bleeding. And acute normovolemic hemodilution, it can also be planned in high-risk patients with high risk of bleeding, similarly, so that if the patient can improve his hematocrit over a period of time, where erythropoietin and iron therapy, there is time for the same thing to do. These also. And intraoperative and postoperative management of blood loss. In this, the four main components of is allogenic red blood cell transfusion, reinfusion of red blood cells, intraoperative and postoperative patient monitoring, and treatment of excessive bleeding. Of these, the main important thing is, so I will talk about reinfusion of recovered red blood cells later in the part of the session. Allogenic red blood cell transfusion is, as we have discussed, at restricted transfusion threshold should be followed where and when possible, and can be relaxed in patients with critically ill and cardiac diseases. So coming to intraoperative, intraoperative and postoperative patient monitoring. The monitoring involves the observation of the surgical field for microvascular or macrovascular field, and it should be done periodically, every 15 minutes, 30 minutes. It has to be discussed with the surgeon how the surgical field is and how the bleed is happening, or it has worsened or improved. So periodical discussion with the surgical team improves the assessment and knowing the response of the transfusion which we have given. And quantitative measurements of blood loss also has to be happening. We like measuring the suction canisters, mops and gauze, weighing the mops and gauzes, and visual assessment. So more objective methods of assessment, measurement of blood loss would be better than just a visual assessment. It's better. It is more objective way of measuring or quantitating the blood loss is more recommended. And monitoring of perfusion along with the vital parameters. So the ABG would give us a lactate and mixed venous saturation, cerebral oximetry, when and where it is instilled or available, it can be utilized as an additional monitoring technique for a peripheral perfusion. And estimated blood loss has to be assessed prior to the surgery. During the surgery, the blood loss has to be assessed, and the clinical signs also have to be correlated, and the decision has to be taken whether what the patient is requiring at that particular moment of time. And standard coagulation testing like PT, APTT, INR, and fibrinogen levels, and a viscoelastic assays, if available, can also be instituted and utilized during the surgery for monitoring purpose of the coagulation of the particular patient, where the patient is more and responding to our therapy, or you're not aware what has, or you want to know where the response of our therapy, how much it has responded well. And monitor for transfusion reaction. This has to be happening continuously. Because most of the patients which we are giving, the transfusion which you are giving, the patient is anesthetized under the drapes, will not be most of the times assessing for it. So continuous idea about the vitals and the temperature, and repeatedly examining for any other reactions has to be happening continuously. And treatment of excessive, so there will be any patient who is bleeding excessively, which is more than the expected thing during the surgery, the transfusion, or after the blood component therapy. There's always idea of platelet count to be done, or a coagulation or a fibrinogen levels assessed before transfusing any blood and blood component therapy also. So it also depends on how robust our lab reports would come sooner, or it will take time, and accordingly whatever is feasible by the particular institution has to be instituted. And desmopressin in cases of excessive bleeding and platelet dysfunction can also be given. And topical hemostatics like fibrin glue at the surgical site or a thrombin gel has been used recently. Antifibrinolytics are also recommended, as mentioned earlier, and prothrombin concentrates and recombinant factor 7. All these components were assessed separately. So combination of therapy, combination of all these components is not studied much, but each of these components have been shown good results in mitigating the blood loss. So now, after knowing all about the patient blood management, now where we have discussed the patient, a cancer patient, or whether it is for cancer, how different is a cancer patient? Right now, it is what ASA has given, all the ASA recommendations or the physiology remains intact for all the patients. But how differently we have to think, or what are the considerations in a patient who is having cancer or a cancer patient which we are dealing with on a regular basis. So, in a cancer patient, most of the solid tumors, anemia sometimes is an associated sign of it is a sign of the tumor as well. Like it could be bleeding from the surface of the tumor, it could be overt bleed or a occult bleed, like a gastric tumors and all. Would a patient would have a history of melena persistently over a period, and they will be having persistent 6, 7, or 8 hemoglobin requiring multiple transfusions. Second thing, and bleeding here, colorectal tumor who would be bleeding persistently. That is one thing. Any tumor can bleed from its surface. It could be overt and open. And cancer itself is a chronic inflammatory state, which is a functional anemic state. The functional capacity itself will come down, and over a period, low hemoglobin and transferrin saturation is also seen in these patients. And advanced disease, in cases of advanced disease, the cachexia and anorexia would add to the nutritional worsening of the patient. So that even worsens the anemic status. So risks of transfusion, as we all know. But the most important thing which we are interested in a cancer patient is the cytopenias, like transfusion associated graft versus host disease, or it is mainly the transfusion related immunomodulation, which is everyone is most interested in. Like the as we say transfusion, it is almost like a transplantation of someone's blood into someone else's body. Like the body, it is an allogenic blood transfusion, right? So the body responds to that particular antigen coming in, and that blood itself carries some immune potential. So so there are multiple mechanisms which were studied how the transfusion itself would affect the patient's immunological system, right? So once the blood is transfused, so there will be multiple cellular molecules and molecular components, like some WBC, some extracellular vesicles of the donor blood, and free hemoglobin and iron, which will be increasing over a period of, as the patient blood is stored over a period of time, and CD40. So these all would have secondary effects on the patient's body, like release of interleukin 6, 10, TGF beta, and free radical generation. These all would increase T cells, decrease natural killer cells, which is a protective mechanism, like anti-cancer cells. These are, and decrease the phagocytic function, increase in vascular endothelial growth factors. These all will create a pro-cancer, pro-tumor environment in the patient's body, whoever is receiving the blood. So we don't know how much impact the blood transfusion might cause in patients. Would really lead to a cancer, right? One blood transfusion, or how many water, blood or blood component transfusion, we really don't know. But there is a clear impact on the immunological system of the body. But the impact of this immunological system, whether it leads to increase in cancer or not, is not really completely studied. Now, recently in June 2024, there is a narrative review which is published in Current Oncology Reports about perioperative blood transfusion and cancer progression, and what the studies which were done in the last decade, and multiple retrospective analysis and studies were compiled, and they have addressed multiple issues or multiple concerns in a cancer patient where we could modify, or there are doubts in oncoanesthetists or any oncologist whether a blood transfusion is really impacting it, and what are some aspects of blood transfusion, like a WPC component in a blood, or the leukoirradiation, or there are multiple components which will go ahead and get to know what does the evidence say, right? So the leukoreduction, which is usually the preferred we would be knowing, most of us, all the hematological malignancy patients would be receiving leuko-irradiated blood transfusion where and when required. So whether that effect of leukoreduction is really helping out, or whether it is impacting cancer recurrence or not, has studied, and it has proven that HLA alloimmunization rates have been reduced with leukoreduction if it is additionally gamma irradiated. A number of invariant CD4 NK cells and T regulatory cells and concentration of interleukin 10 have been decreased. This was studied in Transfusion Journal in 2019. And in the same way, in a operative setting, like a major spine and orthopedic surgery, whether this is really showing it up or not has been studied. And it is the outcome as the levels of TGF beta. But the main confounding factor for this study was post-operative status itself is increasing. The surgical stress itself is increasing some molecules which have been studied as a component of immunomodulation. So even with that, further analysis was done, and they have reported that allogenic blood transfusion did not show much response in the immune response, but on the components or molecules which they have studied in major orthopedic surgeries. So impact of the surgical technique, like we all know the impact of the surgical technique causes surgical stress. The surgical stress would lead to release of some cytokines. And these cytokines, do they really impact cancer progression or recurrence? It's been studied, and as usually open versus minimally invasive, when it is studied, the minimally invasive surgeries have been proven to be better in mitigating the surgical stress response. And eventually, once the advent of robotic surgeries have been rampant and pelvic surgeries, the lab versus robotic has also been tested. So the surgical stress response, when tested with post-operative CRP levels, has been very much low in robotic surgeries and compared with lab surgeries. And eventually, if it further analysis was done to test that robotic surgeries have required a very few blood transfusions, or a few lesser amount of blood loss has happened, lesser amount of blood has been transfused for these patients. So eventually, if we really think that transfusion related immunomodulation would really impact the patient's oncological outcome, a minimally invasive technique in a selected patient would really decrease the effect of or side effects of blood transfusion as well. But conversely or contrastingly, cervical cancer patients who are operated have shown a lower disease-free survival in minimally invasive surgeries with almost 75% increased risk of recurrence. So next, whether the transfusion threshold. The next thing is transfusion threshold, whether it has to be specific for a patient who is undergoing some particular cancer or who has some particular cancer or a particular cancer surgery has been studied, but there is very limited evidence that for a cancer-specific transfusion threshold being liberal and restrictive, the restrictive threshold remains intact for most of the cancer surgeries until unless a patient is critically ill or having cardiac dysfunction or cardiac compromise. But interestingly, there is one retrospective cohort which was done recently in 2022 in UK. It is followed by a survey with surgeons, critical care physicians, and the anesthetists. The retrospective cohort, along with a survey of 412 patients who have undergone intra-abdominal malignancy surgeries for intra-abdominal malignancies. The mean pre-transfusion hemoglobin was around 7.5, which was tested with different methods. It could be a standard method or a HemAQ, the other testing, point of care testing methods. And a post-operative hemoglobin was found to be average, which is 10.3, and the rate of myocardial injury was estimated to be 4.1. But being an observation study, the other interesting fact of this particular study is, during the survey, the most clinicians have the highest rated concern for blood has been rated as immunomodulation and cancer progression. So this highlights the awareness of the effect of blood transfusion. So this awareness would improve the decision making or improvement on management or perioperative management of that particular any patient who is having or prone to have increased. And all clinicians that active to patients with cardiovascular disease. So whether volume of it's okay. Now till now we have thinking whether to give PRBC or not PRBC, no PRBC. So but eventually we are landing up in a situation where PRBC have to be given with the amount of blood loss our surgeons cause has to be given. But how much? Whether the volume of PRBC which is given would really affect or impact the cancer progression has also been studied. And dose there is it is found to be having a dose dependent relationship between PRBC transfusion and cancer progression, and mainly in ampullary cancer, malignant peritoneal mesothelioma, pseudomyxoma peritoneum, other thoracic and renal tumors, it is found to be having a dose related dose response relation. Means the more the amount of Paxil given, the more is the amount of, means more is the risk of cancer progression is what was found out. A series of 67 patients undergoing curative pancreatitis showed so how many, means more than one, more than two, that also they wanted to study. So it was studied. So patients who have received more than 3 units of red cells or more had a worse 3-year survival and a 5-year survival compared with patients who have received 2 and less than 2 vaccines. So this also is another observation study. Its applicability in generalizability is a question, but it is one experience which needs to be kept on our mind when we are tend to or making a decision to transfuse multiple Paxils back to back. So it is always important to reassess the indication rather than chasing some numbers. So patients who had poor immune nutritional status and a more aggressive tumor characteristics are also were the ones who have received more transfusions in the study. In multiple studies, it has found out that poor immunonutrition status and a more aggressive tumor, which is obvious, right? So other major concerns, whether intraoperative autologous transfusion, where the red cell, as I said, the red cell salvage, and whether it can, so major concern in the retransfusing the red blood cells in the patient's back is the main concern for all anesthetists or the surgeons or whoever are involved, is whether that particular blood would contain tumor cells, right? Whether that blood would contain some components of the tumor which would further progress the disease or metastasize the disease. With this much effort, the tumor load has been decreased, and with all this blood transfusion, are we reaching the tumor or the risk of the patient to metastasize or recurrence, right? So now again, but it is a big no with what all the studies have proven. Metastasis is a complex process. It is not that simple that a cancer cell has been transfused and it can metastasize to wherever the blood travels to, right? So it is a complex process. Not all circulating tumor cells metastasize, even if we circulate a tumor cell. The second thing, after the filtration, processing, and all the whatever tumor cell has been collected in the blood is not the same at the end of the processing. Like after the filtration and all processing, the tumor cell, even if it is there, any might get damaged. There will be a cellular damage, which would make really important. Means it is not the same potency. The metastatic potential would not be the same. And the leukocyte depletion filters, how the efficacy of those leukocyte depletion was noted to be 99.6 to 99.9% of clearance of any other cellular debris in the red cell concentrate which is collected. Yeah. And so then there is, in spine tumor surgeries, it has been studied whether LDF usage would really make an impact in patients' metastasis or not. But it was proven that even without the leukocyte depletion filter usage, it is shown that it doesn't really matter, because the metastatic cells or tumor cells which were collected in the surgical blood or blood from the feed are not the same as the cells which have caused the tumor for the patient. So the same thing. So now it is well known, or at least established, that it is not a big concern, that it will not really metastasize or it will not increase the tumor progression risk. It was tested, and again liver resection or liver transplantation surgeries, and it shown it is not it has reduced the intraoperative allogenic RBC transfusion without compromising oncological outcomes and less impact in immune function. So now, till now, we are concerned about immunomodulation, right? Immunomodulation happens because the blood or the blood component is coming from someone else's body, someone else's immune system. right? And that immune system and the patient's immune system are fighting, and that would really affect the immunocompromised cancer patient. This is our hypothesis till now. So now coming to autologous blood transfusion, again the hypothesis is changing that that tumor will cause damage to the patient, right? So now the patient's own blood, if it is transfused, the immunomodulation risk is almost minimal, right? Because the patient's own blood, patient's own WBC, if any, are being transfused. So the reaction or the immune modulation, the reaction of the immune system is most minimal when autologous blood transfusions are done. And the risk of cancer progression was reduced in patients, recipients of autologous salvaged blood with or without LDF as compared to non-transfused patients. And usually it is not only the cancer progression, the amount of blood transfused, also allogenic blood transfused, and the load on the blood banks have decreased. The amount of other blood component therapy also would decrease. But main limitations of this particular narrative review, or all the studies which were almost, they have studied almost 1200 or some odd studies and checked for analysis or checked for outcomes. So the main problem with blood transfusion and cancer progression is both of them share similar risk factors. When do we give blood during a perioperative period? If the tumor is big, if the tumor is involving the vascular structures, or the resection involves multiple visceral resections, or eventually the duration of surgery increases, and the patient, if has this extensive disease, would be functionally low or anemic, nutritionally low prior to the surgery. Advanced disease patients also would require increased transfusion. So we don't really, the main limitation is that because both of them, the cancer progression also would have the same thing. With the advanced disease, there is an increased risk of progression. The size of the tumor is independently related to the risk of disease-free survival or recurrence or lymphovascular invasion itself. So all the factors which are having high risk of perioperative blood transfusion are also sharing the risk factors of cancer progression. So how much we could relate this to that is a question, but yes. But yes, the further propensity matched analysis was done, and it has proven that where the patients are receiving increased blood transfusions, there is increased risk of cancer progression or metastasis. So now coming to the case summary, where all we would have intervened and modified with all the knowledge we have acquired till now. So the same patient who's been diagnosed in a OPD, probably some 3-4 months has received radiation and Folfox. She would have, it can be instituted in a way that when eventually with this advanced surgery after the chemotherapy, even though the reassess, the patient would have come to the hospital for at least 7 to 8 times till the whole duration, means after her chemotherapy and radiation. So any of the time, as early as possible, if the patient visits to a perioperative as an anesthetist or attending anesthetist, the perioperatively we can address the patient's anemic status, nutritional status, and a overall functional status. So the patient would have been, as I said, the patient has just visited 72 hours prior to the planned surgery. If the patient would have addressed at the time of visited the PSC clinic at the time of diagnosis or any of her chemo or radiation sessions, we would have addressed her and evaluated her, diagnosed any other blood or hemoglobin related issues or nutritional issues, and it would have been addressed and optimized well and planned. Eventually, even if it is not a pelvic excision, it would have been other colorectal resection depending on the disease status. So eventually it is moderate to major risk surgery for blood loss and blood transfusion as well. And at the time of so if we would have intervened way earlier, she would have received appropriate she would have been evaluated for iron studies. If she is nutritionally ill, nutritionally we would have improved her with iron therapy. We would have had a better preoperative hemoglobin and better functional state. And intraoperatively, so as I mentioned, the final blood loss is 4.8 liters. If we would have monitored periodically the surgical status, the amount of blood loss which has happened would have decreased. If we would have a good discussion with the patient, we would have preferred a laparoscopic total pelvic excenteration over an open pelvic excenteration if the surgical expertise is present. And a final blood loss of 4.8 would have been decreased on periodic monitoring of periodic visualization of the surgical field, discussion with the surgical team. With a good cooperative team, we would have monitored for intraoperative or a point of care hemoglobin testing. Or if the lab is quick enough, we could get a standard hemoglobin. And a coagulation testing also we would have done, which is probably we would have improved in this. And so that then the amount of crystalloids would have come down and the amount of blood or blood products would have been more matched depending on the amount of loss. And so point of care viscoelastic testing also would have guided us avoiding unnecessary transfusions, or it is not only to avoid unnecessary transfusion. The viscoelastic testing would help us give the necessary transfusion as well. We don't know whether the patient had a low platelet, which has caused all this. So that was, we would have improved.
May I,
and post
please, Virenchi, we need some time for the discussion. Please, please fast.
Yes, sir, it is done, sir. Yeah. So there are n number of the other methods where we would have improved. The point of care testing and intraoperative monitoring helps the better outcome of the patient. So awareness and education of patient blood management has implementation of patient blood management program was associated with 23% lower odds of receiving PRBC transfusion perioperatively, and also improved the hospital length, decreased the hospital length of stay, and improved postoperative morbidity and mortality in a study which was done in US. Awareness. So the take-home message is the cancer patients are different. Transfusion-related immunomodulation and cancer progression both are multifactorial. Patient blood management protocol implementation plays a very crucial role, and operative evaluation and management of anemia is most effective and also cost effective for the patient. Multidisciplinary involvement improves operative blood management strategies, and education in patient blood management is more important. Thank you.
Thank you so much, Dr. Vinci, for wonderful, comprehensive aspect of covering the topic. It was indeed an extensive topic. There is one question as of now. When we talk of auto transfusion, yes, it's one of the important aspects, but there's always a concern that can they safely be used in cancer patients? So what's your take on to this when we talk about auto transfusion in cancer patients?
Yes, that is what, sir. It was well tested in my previous slides. It can be auto transfusion. Would the main component is metastasis or the tumor cell transfusion increases, but with the filters and all, the tumor cell is not the same, which has collected from the surgical field. The cellular damage happens, and it will eventually become impotent. So the tumor potential or metastatic potential will decrease. Second thing is. It will decrease the immune modulation part because it is the same patient's blood which is being transfused. So the immune modulation component is decreased. So both of these is a win-win for the patient.
Absolutely. I think it has to be, as you rightly said, it has to be weighed again its importance. But now the newer filters which are coming up, they can be very comfortably used. Dr. Vinci, just a small opinion from you. In earlier days, there was techniques of hemodilution techniques for blood conservation strategies, and also the increasing number of pharmacological agents for reducing the blood loss during the cancer surgeries. So what will be your package for cancer surgical patients? Because you said you have already mentioned so many aspects. So let's say you have a patient in which the expected blood loss is around 1 liter or maybe 1.5 liter. So what package will you use? Hemodilution technique, GCSF, the pharmacological agents, the auto transfusion. So how will you go about it? Can you just summarize it in a nutshell for all of us?
Yes, sir. So the main advantage of having a cancer patient for a surgery means that most of solid tumors are planned for a surgery if detected or reported to the OPD earlier, diagnosed earlier. So it is better to introduce a protocol where the patient visits us sooner than just once the patient is on the list in their week. Rather than that time, if the patient visits us sooner, then it will give us time for evaluation. So studies can be done if most of the patients in our Indian population, subcontinent population, are nutritionally challenged. So the nutrition status and the iron therapy would at least decrease the risk, means improve the patient status by the time he or she is ready for the surgery or plan for the surgery. So 1 week of iron therapy and 6 weeks or 4 weeks of iron therapy is a great difference for the patient if really iron is low. And GCSF and all, I'm not really, I did not find any much of literature which would really suggest a greater advantage giving GCSF or any other components for the patient prior to surgery. But therapy is one important thing. And if the patient has a rare blood group, or we are expecting too much blood loss, now as you said, 1.5 liter, if the patient visits us early, can be mitigated better. But if we are expecting more blood loss, like autologous patient self donation and improving therapy can also be planned. And if not, if it's less economic hemodilution, yes, but for amount of 1 liter, I don't think if the patient is optimized well prior to the surgery would be a better choice. So intra-op periodic monitoring and viscoelastic testing, point of care testing also would play a better role in deciding where and when the patients require which component of therapy. The same patients, if we are not using the point of care testing, when chasing the numbers on the monitor would also land up the patient in a dilational coagulopathy, where a patient would be receiving more and more crystalloids, where the patient is losing blood with just vasopressors. That is what would have happened to the previous patient, where the postoperatively it is persistent ooze and high drain output. So the package would be early visit, long duration, as long as possible, optimization, and intraoperative periodic testing and assessment of blood loss, and surgical involvement where approaches would be better, and post-operatively persistent monitoring for improving anemic state.
Absolutely. And you have summarized the things very nicely, because there are different aspects which are not, some of them like hemodilution techniques, they are not very commonly used nowadays. It was for orthopedic and spine surgeries, so not very common. But one point, very important point that you mentioned is the point of care investigations that we are doing it, like TAG or similar things. They are actually making us giving the blood products which are required for that particular patient, rather than giving a conventional technique of giving 1:1:1 or something like this. So I think that is itself reducing the requirement of blood products in these patients, which you rightly mentioned in your slides, that they are immunomodulatory and can affect the outcome of these patients from various aspects, not only for the cancer per se, but also because of the surgical issues. They can bring about various concerns. So there is another question from a lot of appreciation for you, actually. It was indeed a good presentation, Dr. Venchi. Is there any single intervention in PBM that you have found of use in the perioperative period?
Yes, sir. The single, if we have to mention in our varied Indian population or Indian anesthetic practice, is a single intervention, at least any patient, it could not be a cancer patient, any patient, if we could practice the patient visiting the surgeon and anesthetist on the same day or within 2 or 3 days, there will be a lot of improvement. So if we could, means it is some acceptable fact that where most of the times, or at least 50% minimum of the times, the patient will be visiting the anesthetist a day prior, just most of the one thinking that there no comorbidities, but most of the patients are be having hemoglobin 9.5, 10, 9, 10. So the same patient would, her iron reserves we would have improved at least for a week or 2 weeks, will make a major change. Because remaining all will require resources, like point of care testing and all would require resources. This is a cost-effective intervention where we have to just talk to the surgeon, where the patient is planned for surgery, would be visiting the anesthetic OPD also at the same time, so that anesthetic and intervention can be done. Like the nutritional intervention can be done, which would improve minimum 50% of decrease of 50% of transfusion.
Perfect. I think perfect. You covered in your session such nicely, and with the example that you've shared with summarize, I think not many questions, just the acknowledgement and appreciation for your good session. And being Independence Day, I think people wants to celebrate in some way today. So I think we are exactly dot on time. It's 7:30. So we'll stop here, and I'm sure that Dr. Vinci will be available for all your questions. We can put in SOPC official group, and I'm sure he will be more than happy to answer your questions also. There is one question also. We can take it, I think, another 1 minute. Can FFP be used instead of colloids like albumin?
No, FFP should not be used as a plasma expander, never, because as we have discussed, because of all the effects, it should not be considered as a uh,
Absolutely, it's not a
plasma
replacement.
expander.
Yeah, you rightly said it should be used very judiciously. Dr. Deepa wants to ask, very informative talk, so appreciation for you. TAG guidelines to transfuse the right regions. An advantage that I found to be of benefit during post-operative period, it's used in helping us know that we have reached a hypercoagulable state. Absolutely, I think not a question, but she has tried to summarize you what we were discussing. And this point of care thromboelastography and ROTEM, whatever we are using, I think they are definitely useful to guide specific blood products at the right time to be given to these patients rather than conventional techniques. So thank you once again. Yeah,
it is also important in the post-operative period where major abdominal surgeries which we have been doing. So the high colored drains or wherever it would guide us, at least prevent re-exploration. Coagulation has been immediately addressed.
Absolutely, I think this will add on to the previous question that we're discussing, that FFP to be given. I think that will all take care whether FFP should be given for that particular purpose. It's not for replacement of albumin actually. And when we talk about cancer surgeries, a lot thing has been said about the prehabilitation and the anemia management pre-operatively, whatever time we have, 2 weeks, 3 weeks, 4 weeks. I think that takes care of not only about the anemia management, but to a certain extent, the nutritional aspect, taking care of the albumin is also being taken care as a part of prehabilitation in these patients. We need to include them rather than giving blood products as the protein products or just improving it. So I think we have to have those components integrated so as to decrease the requirement of blood as far as possible during the perioperative period. So thank you once again, and shoot it by 3 minutes. So thank you so much for a wonderful session. And I will hand over the session to Dr. Sohan Solanki, Secretary SOPSI, for the final comments and closure. Over to you, sir.
Thank you, Dr. Rakesh, and thank you, Virinchi, for a wonderful talk, and Dr. Rakesh for taking questions and discussion about the topic. So I think this topic was really well covered today with your expert comment, Dr. Rakesh. So I think we should stop the session here now. So Shreyasi, you can close the session now, please.
Thank you, sir.
Yes, Shreyasi, there?
Hello, sir.
Yeah, please
Yeah.
end it.
Yeah, sure. So with all your permission, sir, I'm closing the session over here for today. Thank you so much.
Yeah.
Thank you.
Thank you.
Thank you, everyone.
Yeah.